Liver cancer is the sixth most common cancer in the world, with a low overall survival of less than 2 years. Efficiency and effectiveness of its treatment has to be improved to save lives and resources. Open surgical procedures often aren't reasonable, as in the case of severe cirrhosis. Because of the loss of significant functional liver volume, with additional drawbacks like the relevant rate of complication, the risk of infection, long recovery, and reduced quality of life. In fact, less than a third of the patients with liver cancer are feasible candidates for surgical treatment. Alternative, less invasive treatments are requested. That's why minimally invasive procedures like RFA, radiofrequency ablation, are on the rise. How does RFA for liver tumours work? Local treatment uses precise imaging guidance to insert a needle into the tumour tissue and pass on alternating electrical current to destroy cancer cells in a defined area with heat, while sparing surrounding healthy tissues. The advantages of image-guiding RFA are that there is no relevant skin cut, less impairment of organ function, fewer complications, faster recovery, and thus better quality of life. Especially for early cancer, which shows equal overall survival rates and long-term outcomes compared with surgery. However, there are still challenges and space for improvement in the potential for better control of the heat-induced lesion. The fixed treatment protocol of the manufacturer does not respect patient-specific parameters. You see the RFA probe placed precisely in the tumour. The blue circle is the ablation zone according to the manufacturer's protocol. Black is the real result. You can appreciate the deformation of the area around the vessel due to its cooling effect, so-called heat sink effect. Heating changes are not visible on CT images while ablating, left. The real lesion size will only be demarcated on the follow-up CT scan about 1 month after the RFA procedure, right, and it can be larger or smaller than expected. This heat sink effect, due to a large vessel, can result in local undertreatment with following tumour recurrence. But also, overtreatment can occur with destruction to much surrounding tissue and harm relevant structures like bile ducts, resulting in severe complications. A precise and reliable prediction of the ideal ablation zone could lead to adapt the ablation protocol and potentially lead to a better result and to avoid under and overtreatment. So how can we do this? RFA Guardian is a software tool which has been developed to accurately predict the real size and shape of the resulting ablation zone during the procedure itself. This enables better patient-specific planning, leads to precise treatment, and at the end, gives the radiologist confidence to avoid over or under treatment, and a high degree of effectiveness. RFA Guardian has a 3-stage workflow. 1. Pre-interventional planning. Contrast-enhanced computer tomography allows to generate high-quality image slices of the body in an extremely short time. A 3-phase enhanced CT scan and perfusion scan of the liver is acquired in one short session, about 3 days prior to the RFA. A dedicated software allows immediate calculation of the tissue perfusion. The scan is used to generate a 3D anatomical model of the patient's liver, vessels, and tumour. The resulting segmentation of different vessels, tumour, and liver surface is transformed in a volumetric mesh, which serves as a basis for the next stage to run the simulation of the RFA procedure. Based on the volumetric mesh, an innovative algorithm allows precise calculation and visualization of heat transfer and simulation of the lesion in the tissue. 2. Peri-interventional simulation. Everything is done in the same way as in the conventional image-guided RFA procedure. CT-guided placement of the probe, a single native CT scan is acquired with the RFA needle in its final position. This is used to define the RFA needle's geometry and register the needle within the pre-interventional anatomical model. Now the RFA procedure can be simulated on the graphical user interface with different needle protocol extensions, as well as patient-specific liver and tumor perfusion, to predict an RFA lesion within the 3D anatomical model. Thereby, the interventionalist can potentially adjust the planned RFA protocol to achieve an optimal clinical result. 3. Post-interventional validation. The simulated lesion is validated against the patient's post-interventional CT scan after 1 month, where you can appreciate the lesion nicely by segmenting, registering, and comparing the RFA lesion with the lesion simulated in Step 2. This is important for quality assessment, but the computer-assisted follow-up of the thermal lesion plays another crucial role. Generally, the lesion should shrink over time. Even the slightest increase, which may not be visible to the naked eye, but detected with the computer, can indicate tumor recurrence. Such early occurrence can be safely treated by RFA. There are a number of potential applications and groups who can benefit from this software. 1. Routine medical uses for real, patient-specific treatment planning in difficult cases, multiple ablations, and nearby critical structures like bile ducts and large vessels. 2. Training residents, students, and technical staff in learning medical institutions, technical challenges, handling the clinical workflow, and technical requirements. 3. For scientific purposes, such as the evaluation and development of advanced medical equipment. RFA Guardian has been created to maximize the benefits of RFA. This innovative software helps deliver safer, patient-specific treatment for primary and metastatic liver cancer, and crucially, gives interventionalists greater confidence in treatment planning. It's possible to train more doctors and push the limits, treating more tumors in critical areas or larger or multiple tumors, spreading the technique of minimal invasive ablation to make it available for every patient. Let's work together to generate better long-term outcomes and higher quality of life for patients with liver cancer.